Assalamu alaikum rahmatullah. Sallallahu ala Sayyidi Rasulullah. Thank you so much for being with us here today, and bear with us. So there is this lecture, and then the best is coming. Dr. Raghda, we kept her to the last because she's the smartest and she's probably the best among us. So we're almost done. And I'd just like to mention that probably you're going to find me a bit sleepy today. I just decided to be Americanized this morning. So I wake up in the morning, I went to the gym. Yeah, I felt like I want to be American, and now I'm very sleepy and having back pain, so don't do that. Forget about it. Anyhow, so we're going to now come and talk about pulmonary hypertension. So these are the 5 groups that Dr. Hussam did talk about. The 5 PAH is the group 1. I'm going to be talking about today about the treatment. Group 2 is the left heart disease induced pulmonary hypertension. Group 3, that what Dr. Raghda will be talking about, is a PH caused by lung diseases and hypoxia. Group 4, the CTEPH, and group 5 is when you have multifactorial things. And as Hussam said, CTD can present, or scleroderma in general, in all of these 5 groups. So this is very important when we make a diagnosis of pulmonary hypertension with a scleroderma. It's always important to basically figure out in which group, because we cannot go wrong there. We need to really classify the patients into the right groups in order to improve. You've seen that. So really scleroderma is not uncommon. Basically PH is not uncommon when it comes to basically scleroderma, and you know that. What kills those patients is when you have really lung disease, and those are the one that have the worst. Those are the one who have ILD PH with the scleroderma, and that we left that to Dr. Raghda to really cover that up, because those are the worst guys. But even those who have PH or those who have ILD scleroderma, they don't do very well as well. And if you look at among different basically risk factor for mortality among PAH, scleroderma score number 1. So scleroderma PH is the sentence of death. That's extremely bad outcome. And this is why we apply the screening methodology, as Hussam told us, trying to pick up those patients early, optimize treatment, and if we do that, we get the best outcome of those patients in an outcome very similar to other basically classes. This is our data from the Prince Sultan Military Medical City. Our first 100 patients, when you looked at, and you look at those green guys, those are the CTD scleroderma, and you look at the outcome compared to the idiopathic, which is the red, or the congenital heart disease, which is the blue, you can see that scleroderma people did not do very well. Now, this was back on 2015. We are doing better now with a better medication that we have. So what's wrong with those patients? Why those patients are in trouble? I think that slide will really summarize what happened with those patients. The whole problem with the pulmonary hypertension is this kind of relation between the right ventricle and the pulmonary artery. As long as the right ventricle is able to push the blood forward to the pulmonary artery, that patient will be okay. Now, once you have this problem, this kind of relationship that we will call RVPA coupling, as long as this is maintained, your patients are doing fine. Once this is becoming like uncoupled, or the RV now is really struggling in pushing the blood forward, that's where the patient will be in trouble and the patient will die. So if you think about it with the kind of simplicity, it is about the contractility and moving the blood forward by the RV and the afterload that come from the pulmonary artery. So we look at what we look at is really the basic insystolic elastance on the pulmonary artery elastance. So that's the whole thing. That's what we are doing when we deal with those patients. Is the RV coupled or really uncoupled? And when you look at what happened in scleroderma, it's even worse, because the really problem that it's not simply between the RV and the pulmonary artery. The heart itself is abnormal. The myofiber itself is abnormal. And the pulmonary artery as well is really stiffer than normal. So those people, normally in you and I, when the RV contract, the pulmonary artery initially dilate to accommodate the cardiac output and keeping the really flow going smoothly. In the scleroderma, that's becoming really blunted. So what we call about the pulmonary vascular resistance does not really reflect the total pulmonary resistance which comes from the stiffness of the pulmonary artery. So it is really a problem between this RV, PA coupling and coupling that happen really in those patients. And a study trying to look at what happened to the myocardial really perfusion in those patients. In you and I, if we start exercise, like what I did this morning, basically you would see that the more red you get, this means the more perfusion in the pericardium. And that's, you can see that in scleroderma, that is really blunted. The perfusion does not increase to the basically fibers to your heart with exercise. And you can see that the perfusion is really blunted to the RV and to the LV, both cardiac chamber getting abnormal perfusion in scleroderma with or without pulmonary hypertension, but it's worse if you have pulmonary hypertension. So that's a problem. So now the heart itself is abnormal. The pulmonary artery is stiff. So those people are in big trouble of RV, PA, uncoupling. Now, when we try to treat those patients, very important, we do not try to drop the pressure. Of course, if we drop the pressure, that's good enough. But our target is to move the patient into the green zone. That's our goal. And if you look at it, what are we doing? We are, in indirect way, improving the parameter of the right ventricle. RV, PA coupling, improving symptoms, basically exercise and RV parameters, which include biomarkers, echo, imaging, and hemodynamics. What we're trying to do is to push the patient into the green zone to get low risk of mortality. And even that green zone is not great. Mortality could be up to 5% per year. If you tell me that I have 5% chance of dying this year, I'll be on some antidepressants. It's not a good thing. Yeah. So this is not good. So even the green zone is not good enough, but it is the best that we can get at the moment. And one of the parameters, unfortunately, again, basically Dr. Hani is not here today, is talking about those patients where we have now a non-invasive methodology to pick up this uncoupled. We look at this guy here, what is the echo? Echo parameter. So the TAPSE over the systolic pulmonary artery pressure. Now we are asking our basically cardiologists to look at this, because once this is less than 0.3, we know that the RV is unable to push the blood basically well, and we call that the uncoupling non-invasive hemodynamic monitoring. So if you look at those, for example, patients, same pressure, very dilated RV, very normal RV, those patients will behave differently. So basically having the same pressure, those people will not do basically the best. So how to manage those patients? Now, remember this, that is really our goal. And you would like the patients to be in the green zone. Now, people were looking at what's the rationale behind it when it comes to CTD's pH, and we found that many studies have shown that if the patient is really in the green zone, they will do much better when it comes to the basically survival, and the more criteria of the green zone they have, and the French went to you're gonna get better outcomes. So these kind of symptoms, exercise, biomarkers, echo, MRI, hemodynamics, the more we get, the better the outcome to those patients. We use medications trying to target multiple signaling pathway. I'm not going to go over the medication here today, but we're talking about class of medication. So we can either replace prostacyclin, so we can give prostacyclin to the patient to accumulate cyclic AMP, which is a good guy, the good molecule that produces a lot of vasodilatation. It has anti-inflammatory effect, really prevents platelet aggregation, anti-proliferation, or we can kind of enhance the function of the nitric oxide pathway by giving medication to maintain cyclic GMP or to directly stimulate the recruitment of really converging to the active cyclic GMP via SIGWAT. We can inhibit endothelin receptor basically pathway, which is, if you look at endothelin 1 is the most potent basically vasoconstrictor and promotes cell proliferation. So inhibition that is a good idea. It will induce vasodilatation. And nowadays we have drugs to restore the balance between proliferation and anti-proliferation. So tatacept now is now available to us, or will be available to us in the near future. So we have multiple drugs that we can use, and we do use them in combination. So this is why we're talking this morning about in the ILD, would like to see this aggressive combination therapy from day one. We do that in pulmonary arterial hypertension. We use 2 drugs from the beginning, and probably later on 3 or even 4 drugs to keep the patient into the green zone. I'm going to just show you one study. This comes from Johns Hopkins Clinic from Paul Hassoun groups. So they look at 25 treatment-naive patients, PH patient with scleroderma, and of course, this was the old definition. The pressure was more than 25 at that time. Now this changed to basically 20. So basically, those patients were treated with ambrisentan tadalafil. So ambrisentan belong to the endothelin receptor antagonist, and tadalafil is to the basically nitric oxide group, and they treated those patients. But they look at, interestingly, to not usual endpoints. So basically, they look at the RV mass. So they were looking at this RV coupling, uncoupling, change in the pulmonary vascular resistance, and then they look at basically compliance, ventricular mass index, 6-minute walk distance, and pro-BNP. And what they found that this upfront combination does work in scleroderma patients. When they look at basically the PVR, significant drop, the right ventricular mass improve, RV ejection fraction improved, and the pulmonary capacitance improve. And many studies have shown that this benefit of improving the RV PA coupling or uncoupling will be much better if you use multiple medication from the beginning. So this was a retrospective study to show that in order to recover the right ventricle, you need to drop the PVR by at least 50%. So you need to induce a lot of reverse, if you like, dropping in the PVR before the RV recovered. And you are more likely to do that if you are in combination therapy. You are very unlikely to really achieve that level of a drop in the PVR to improve the RV coupling if you are on monotherapy. And many studies have shown that, yes, in order to get that, you need, as a matter of fact, sometimes triple medication in order to do that. As Hussam told us, so this is the ambition data showing that, again, upfront combination therapy between the patients who have group 1 PH, when they treat them with upfront combination versus monotherapy, they found that those who have upfront combination did much better. And that was true for idiopathic PH and for the CTD's PH, including scleroderma PH. So as we speak at the moment, we're treating those patients very similarly to the PH group with upfront combination therapy. There was always question about what's about the immunotherapy. Should we use immunosuppression as we do when it comes to the ILD, when we use a lot of immunosuppression with antifibrotic treatment? So people try to look at that. So there is no much data about this in scleroderma. So they look at 28 patients with PH, and then they look at some of those patients who really received cyclophosphamide, at least 3 doses, and some of them were on even systemic steroid. Those patients were not on PH target treatment. And then they look at those who responded to the immunosuppressive treatment based on criteria. So they look at improvement in the function class, they look at hemodynamic improvement only with immunosuppressive treatment, but not on PH target therapy. And what they found that about 40% of patients with SLE or mixed connective tissue diseases did improve significantly with immunosuppressive therapy, but not patients with scleroderma. None of the 6 scleroderma patients improved with the immunosuppressive therapy. There was 1 RA patient, again, did not improve. So in that study, at least, showed that probably, yes, there is a role for immunotherapy, immunosuppression, but not in scleroderma, maybe on SLE and CTDs. And we look at those who responded to immunotherapy, they have far better response to better survival, better improvement in their function class compared to those who did not respond. So yes, immunotherapy has a role, but probably not on scleroderma PAH, and that's probably understood because of the nature of the disease. So take-home message, PAH CTDs by itself carry very, very bad prognosis, and this is for many reasons, and this is why it's really worth looking for those patients by applying screening methodology in order to pick them earlier and to treat them basically earlier. We know that when it comes to the scleroderma, there is one step behind. It's not simply what's happening in the lung, it is the whole relationship between the RV and the pulmonary artery is disturbed with this really uncoupled really problem because of this intrinsic changes in the myocardium itself and in the pulmonary artery basically wall. So we need to do everything possible to improve this RV-PA coupling in those patients. We would like to keep the patient always in the green zone by keep adding drugs to really reach that target. At the moment, we have 4 signaling pathways that we are using to treat those patients. Usually we start by those 2 and then we really add to them. Hemodynamics and cardiac MRI probably should be incorporated in managing of scleroderma, basically PAH. Immunotherapy does not seem to have a role in scleroderma PAH, but probably it does in SLE and mixed connective tissue diseases. Thank you very much for your attention.